Good afternoon, everyone. My name is Vitusha Vijayathas, and I'm a research student at 3CTN. I am thrilled to have the privilege of serving as a facilitator for the Winter impACCT virtual rounds. We wish to acknowledge the land on which 3CTN operates. 3CTN's work takes place on traditional Indigenous territories across the province we now call Ontario, and we are thankful to the Indigenous peoples who have cared for these territories since time immemorial. We acknowledge that Toronto, where the 3CTN office is located, has for thousands of years been the traditional land of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. Today, we respect and honor the presence of the many diverse First Nations, Inuit, and Métis people who make it their home. We also acknowledge that we are a virtual meeting, that many others may be on different territory as well. So please take the time to reflect on and honor the Indigenous communities of your territories. 3CTN continues to host virtual rounds to support the opening of additional sites for selected portfolio trials and to increase trial awareness across the network. impACCT virtual rounds are held quarterly, and investigators are encouraged to consider bringing forward their portfolio trial for inclusion in upcoming sessions. During the Q&A and discussion period, following the presentations, questions can be submitted in Slido to be addressed. Questions can be submitted live on Slido throughout the webinar session with the event code WINTER. Attendees will also have an opportunity to ask a question live using their raise their hand feature in Zoom or use the Zoom chat. If there are any outstanding questions after the session, we will reach out to you. We will reach out to the presenters and share those answers with you. It is now my honor to introduce our first distinguished speaker, Dr. Elena Parvez. Dr. Parvez is an assistant professor in the Department of Surgery at McMaster University and a surgical oncologist at the Jarvinsky Hospital and Cancer Center. She is a young investigator at the Escarpment Cancer Research Institute in the Faculty of Health Sciences at McMaster University. Dr. Parvez's interests are in de-escalation of therapies of breast cancer and in ensuring equitable access to quality breast cancer care in marginalized communities. Today, Dr. Parvez will be presenting on an exciting clinical trial titled Radiation Omission in Patients with Clinically Node-Negative Breast Cancer Undergoing Lumpectomy and with a Pathologic Complete Response after Neoadjuvant Chemotherapy. Please join me in welcoming Dr. Parvez to share her insights on this exciting clinical trial. Dr. Parvez, would you be able to share your screen? And if there are any technical difficulties, please let us know so we can share them instead.
Thank you very much, Vitusha. Is everyone able to see my screen there? Yeah, okay, wonderful. So thank you everyone for logging in and thank you for allowing me to present our trial. So this trial is the Rosalie trial. It is a trial of omission of radiation in patients with node-negative breast cancer who undergo breast-conserving surgery and are found to have a pathologic complete response after neoadjuvant chemotherapy. I'm the principal investigator, and my co-investigators are Dr. Terry Mwanza, Mark Bassick, Tim Whalen, and Samir Parpia. The study sponsor is the OCOG group, and our funding comes from CIHR. Sorry, are you, there we go. Okay, so just for some background, the management of breast cancer has really been transformed over the last number of years. So for patients with early stage breast cancer, it is now routine that they will be managed with multimodality therapy. So what that means is that they are managed with a combination of systemic therapy, surgery, and radiation. There are particular subtypes of breast cancer which are particularly chemosensitive. And these include the triple negative subtypes as well as the HER2 overexpressed subtypes. And in these particular subtypes, the rates of something that's called a pathologic complete response are very high. And pathologic complete response, what that means is that there is no residual tumor after systemic therapy. Pathologic complete response is associated with an excellent prognosis. And currently, the standard of care for patients who have been treated with neoadjuvant chemotherapy, undergo breast-conserving surgery, and are found to have a pathologic complete response, it is still for them to undergo whole breast radiation. However, the very high rates of PCR that we're now seeing with modern systemic agents as well as the excellent prognosis in patients with the PCR, has led a lot of people to question whether we can de-escalate some components of that care. So currently, we do not have any quality data about omission of radiation for these patients. But we do have data that suggests their risk of local regional recurrence is very low. So we have a meta-analysis of 9 German neoadjuvant chemotherapy trials, which found that for patients who have neoadjuvant chemotherapy, undergo surgery, and are found to have pathologic complete response, as well as are treated with adjuvant radiation, their risk of local regional recurrence at 5 years is approximately 4%. And in this meta-analysis, they include patients with both node-negative and node-positive breast cancers. So we expect that if we select out node-negative cancers, that risk of recurrence should be even lower. There is more data that comes from a meta-analysis of 2 North American neoadjuvant chemotherapy trials. And in this analysis, the risk of local regional recurrence was only 2.5% at 5 years in patients who were patients over 50. So when we talk about de-escalation of therapy, what that means is delivering optimal care with less treatment, but not compromising recurrence or survival. So because of the low risk of in-breast tumor recurrence and the excellent prognosis observed in patients with a pathologic complete response, a de-escalation trial of radiation is warranted. With these very low in-breast tumor recurrence rates, we suspect that the absolute benefit that can be offered by adjuvant radiation is quite limited. Obviously, a trial such as this would not be warranted if there were no adverse consequences of radiation, but there certainly are. So there are both short-term and long-term toxicities associated with adjuvant radiation. And these include things like breast pain, edema, changes to the skin, fibrosis, and adverse cosmesis. There are also risks of secondary malignancies, as well as development of cardiopulmonary toxicities. And options are also limited for management of recurrences when the breast has been previously radiated. So in this study, the primary outcome is ipsilateral in-breast tumor recurrence at 5 years. And this is defined as recurrence being either invasive or in situ disease. And we estimate that the risk of in-breast tumor recurrence will be less than 5% at 5 years. Secondary outcomes include mastectomy-free interval, the relapse-free interval, disease-free survival, and overall survival. So we do also want to ensure that if there is any marginal increase in risk of local regional recurrence with omission of whole breast radiation, that this is not associated with an increase in distant recurrence or death. This is a prospective multi-center single-arm cohort study. The planned sample size here is 352 patients. And this is, again, based on a calculation where we assume that the actual in-breast tumor recurrence rate is approximately 3%. And if the upper bound of the 95% confidence interval is less than 5%, then we will have met our objective to demonstrate that the risk of recurrence is less than 5% at 5 years. Accrual is estimated to take place over approximately 4 years, and we will follow up patients for a median of 5 years. This is our study schema. So we will have what is called what is a 2-step registration process. So after patients are screened and deemed eligible to enter into the study, their pathology reports will be uploaded into our system and will be centrally reviewed by our study pathologists to ensure that the specimen was appropriately processed and meets the requirements set out by the protocol, and that a pathologic complete response was in fact confirmed. And in this case, the intervention is no radiation. So they will have no radiation, and then they will be followed up for a median of 5 years. In terms of our inclusion criteria, we are including all patients with clinically node-negative breast cancer who have T1 through 3 disease. They can have any tumor subtype. They must have had proven negative lymph nodes at presentation by imaging, so that could be either an ultrasound or an MRI. They should have had a minimum of 8 weeks of neoadjuvant chemotherapy, and those patients with HER2 positive disease must have received targeted anti-HER2 therapy. They must have had a marker clip placed into the tumor bed prior to or during neoadjuvant chemotherapy in order to ensure that the site of disease was appropriately resected when they do get to surgery. They would be treated with lumpectomy and some sort of axillary staging surgery. So that could be either a sentinel lymph node biopsy or an axillary lymph node dissection. And they must have had a pathologic complete response, so absence of residual invasive or in situ disease in both the breast and the lymph nodes. So exclusion criteria include age less than 50 years, inflammatory breast cancer or breast cancer which invades the skin or the chest wall, multicentric disease, history of ipsilateral or contralateral breast cancers, and a hereditary genetic mutation such as BRCA1 or 2 that predisposes them to be at high risk of developing new ipsilateral or contralateral tumors. Other exclusion criteria are another cancer diagnosed within the last 5 years, inability to complete the entire course of neoadjuvant chemotherapy, and patients with hormone receptor positive disease who are not planned to have endocrine therapy, and those with HER2 positive disease who are not planned to receive HER2 targeted therapy, and limited performance status. So follow-up will occur to a median of 5 years. Within the first 2 years, follow-up will be every 6 months, and then following 2 years, follow-up will be annual. I mentioned the central pathology review. So this will be done prior to any patient being enrolled into the study. So the pathology report will be centrally reviewed by the study pathologist in order to ensure adequate processing of the specimen and to ensure that there has been a pathologic complete response. Baseline assessments include things, data that we will collect, such as age, race and ethnicity, height and weight, menopausal status, and ECOG performance status. We will also collect information about the tumor, including size, histologic subtype, receptor status, and grade. Additional information will include the type of systemic therapy that they received, and then ultimately what type of surgery they had, and any endocrine therapy that is planned. Follow-up will occur for the first 6 months, for the first 2 years every 6 months, and then following that it will be annual. We will record all imaging that they have, including annual mammograms, all systemic therapy that they have, including continued immunotherapy and targeted therapy, as well as endocrine therapy. And then if they do, for some reason, undergo radiation therapy or require further surgery. They will be followed for 5 years, and we will record all recurrence events, including local regional recurrences and distant recurrences and death if that were to occur. OCOG will be the study sponsor, and they will be responsible for central monitoring and will coordinate the study. And those are the research coordinators, and that's all I have there. Just stop sharing my screen. Okay. So I'll just looking at the sorry.
Sorry about that. I just want to say thank you for the insightful talk, Dr. Parvez, and I'd like to ask the audience to please input their questions into Slido or the Zoom chat. So I can see our first question states, what strategies do you have in managing concerns from patients who fear cancer reoccurrence when omitting this therapy?
So thank you. That's an excellent question. We don't have anything that's built into the protocol to manage these types of concerns. But importantly, this is a single arm cohort study. So patients are not randomized. So they will know that they would not be having radiation. So we do expect that the level of comfort with omitting this therapy would be reasonably high amongst the patient population. But in terms of any additional supports, that's not built into the study protocol, and it would be based on what's available in individual treatment centers in terms of things like psychosocial oncology support.
Now moving on to the next question. With your interest in marginalized communities, have you considered including strategies to recruit patients from diverse populations in the protocol design?
Thank you. That is a really excellent question. We don't have any sort of discrete strategies that have been included into the protocol design. We do plan to open our trial at centers across the country, which includes more remote centers, and it also includes community hospitals that don't actually have a radiation facility on site, where surgical oncologists or general surgeons will be the primary or the local qualified investigators. And we do hope that that will reach some more rural participants that might not be treated in tertiary care centers. In terms of our sort of study pamphlet that's available for participants, we do hope to have that translated into multiple languages.
That sounds amazing. Thank you for your answer. And now moving on to the last question that's stated, will a cost effectiveness analysis be done as part of the trial's analysis?
Thank you for that question as well. So I think it's a really important question. When we originally conceived this trial, that was one of the important considerations, is that we do expect that with omission of radiation, including the number of visits that are required to come to the hospital, time off of work, and that sort of thing, it would certainly impact cost, and we do expect to see cost savings. But because this is a single arm trial, we have not actually built a cost-effective analysis into the protocol itself. Eventually, what we will plan to do is have a matched cohort, and we'll do that cost-effectiveness analysis with that matched cohort. But for this part of the study and with the funding that we have available, there is no cost-effectiveness analysis. It's challenging to do, I think, in the setting of a single arm trial.
Thank you. And since there aren't any questions left, I think we're just going to end this Q&A segment and move on to the next talk. So we'd like to thank Dr. Parvez again for her very insightful talk, and ask the audience to please email us any remaining questions so we can direct them to Dr. Parvez and share the answers with you at a later date. Moving on, it is my honor to introduce our second distinguished speaker, Dr. Sarah Alexander. Dr. Alexander is a professor in the Department of Pediatrics at the University of Toronto. She is also a clinical director in the Division of Hematology and Oncology, and a pediatric oncologist in the Leukemia and Lymphoma section at the Hospital for Sick Children. Dr. Alexander earned a master's in medical science and doctorate in medicine at Harvard Medical School following pediatrics training at the Boston Children's Hospital. In 2019, Dr. Alexander received the Richard Rowe Award from Sick Kids for providing distinct comprehensive clinical care over a sustained period. Her research interests and clinical expertise encompass non-Hodgkin lymphoma and treatment-related toxicities. Today, she will be presenting on a randomized trial that studies the effect of levocarnitine in protecting the liver from chemotherapy for leukemia or lymphoma. Please join me in welcoming her to present on this very important clinical trial. Dr. Alexander, would you be able to share your screen? And if there are any technical difficulties, please let us know.
Great. Let me know if you can't see my screen. I got a thumbs up. All right, good. So thank you for that kind introduction and for allowing me to bring this trial to this group today. I am speaking on behalf of the protocol chair, who is another pediatric oncologist whose name is Itan Orgal, who is at the Children's Hospital of Los Angeles. And he is really the brains and the brawn behind this protocol. So as introduced, this is a protocol that has the name of ACCL 1931 in the COG world. That stands for a cancer control. The ACCL component stands for a cancer control. So this is a standalone supportive care trial specifically relevant to patients with leukemia. It doesn't seem to want to advance. Hang on a second. There we go. So very briefly, asparaginase is a core chemotherapy agent in patients being treated for precursor ALL. It is a core agent used both in pediatrics and adults, and it has a unique pattern of toxicities. And one of the toxicities is a hepatosteatosis and liver injury, with the basic science underlying it related to oxidant stress and dysregulation of mitochondrial fatty acids. And the mainstay, that it is often a self-resolving, time-limited toxicity, but comes with both acute symptomatic side effects, but also comes with significant impacts on the delivery of effective chemotherapy. The mainstay of measurement of asparaginase-related liver toxicity has been a direct conjugated hyperbilirubinemia. And this is just a table that includes data from a compendium trials done over a compendium of time in adolescents and young adults, looking at the incidence of conjugated bili that is attributed to PEG asparaginase or to an asparaginase product in induction in patients with ALL. And you can see that the rate lives pretty consistently around 20%. The last line is from the Children's Oncology Group last high-risk ALL trial. In children, the incidence is lower. It is known that as soon as you become 15, older, obese, and potentially of Hispanic ethnicity, that the rates increase. So again, just a little bit of background. So levocarnitine is an agent that has been used in multiple diseases unrelated to asparaginase that are associated with liver toxicity and specifically conjugated hyperbilirubinemia. It is a cofactor restoring fatty acid transport into mitochondria. Again, there's extensive experience with its use in other settings, including both clinical use, but also in the context of clinical trials, enough that there are meta-analyses in mainly adult patients looking at its impact on liver toxicity, and also with evidence then around its safety. Specifically in ALL, and one of the reasons for this trial is that it is being used sort of off the shelf currently, both in people's experience from gathering real world data, but also it has worked its way into some of the AYA sort of consensus guidelines as something to consider for patients with asparaginase-related toxicity or who are at risk. So the goal of this study is to build the evidence base to prove or disprove that that's a good idea. There is some existing specific AYA leukemia asparaginase levocarnitine data from a retrospective review or real world data. And this was done in a comparison of an attempt to do matched patients who did or didn't receive levocarnitine. It's clearly retrospective and not prospective randomized, so there's a risk of bias in the matching. But that the bias would potentially favor levocarnitine showing ineffectiveness. And in this, as you can see from the tables, levocarnitine, those patients who received levocarnitine were less likely to develop this conjugated bilirubinemia. The other message from the retrospective study is that the levocarnitine appears to work most effectively as a preventative measure, and using it once you have a conjugated bili, its effectiveness of being a tool to rescue you from that is much less clear. So just to review the rationale for this trial of levocarnitine prophylaxis is that grade 3 hepatotoxicity measured as a conjugated bili is relatively common. It interferes with chemotherapy delivery, and the level of this grade 3 is chosen specifically because the grade 3 hepatotoxicity is the same grade for which most of the common agents in ALL induction therapy would be then either omitted or modified. There's also some evidence again, in retrospective reviews, that those who have this toxicity in induction have less good disease outcomes measured either on an induction MRD or overall outcomes. There are risk factors identified, we already mentioned, so obesity is absolutely a risk factor, and age is a risk factor, and ethnicity of being Hispanic is likely a risk factor as well. So again, the primary aim of the study is to determine in a randomized manner whether the addition of levocarnitine prophylaxis to no prophylaxis, so it is an open label prophylaxis versus not receiving prophylaxis study, to an asparaginase containing induction regimen will decrease the incidence of conjugated bili greater than 3 milligrams per deciliter during AL induction for adolescents and young adults. So this is in patients 15 to 39 years. There are secondary aims looking at other measurements of liver toxicity. There's an aim looking at the end of induction leukemia response or minimal residual disease. There's an additional list of exploratory aims, including evaluations of other life-threatening toxicities, describing the impact, if any, in a rescue arm. There's also some evidence around levocarnitine and neurotoxicity. There's an aim built in to collect patient-reported outcomes suggestive of vincristine-related neurotoxicity during induction. There's an aim looking at adherence. There's an aim exploring the associations between BMI, BSA, age, and racial and ethnic disparities on hepatotoxicity and the potential levocarnitine efficacy. Eligibility, 15 to 39 years. You have to have ALL, lymphoblastic lymphoma, or MPAL treated as ALL. You have to be receiving a BFM COG or C10403 based induction regimen, which are all essentially 4-drug induction regimens. You have to be receiving a regimen that is planned to include asparaginase, which all of these regimens were. You have to have a liver that works at baseline and a reasonable renal function. You can't have longstanding chronic known liver fibrosis, and patients with Down syndrome are not included. This is the schema of the study. Importantly, you do not have to be enrolled on a parent leukemia or lymphoma trial. You can be, and as long as there's not a preclusion of being on another concurrent trial, but you do not have to be. You would, one of the pressures on this trial is that soon after diagnosis, we'll need to be approaching for the study, and enrollment on the study, enrollment and randomization has to happen before the first dose of asparaginase on study. And in the COG regimens, that's generally on day 4 of therapy. Again, it is non-blinded, it's open. You either get levocarnitine prophylaxis or you don't. You then receive your therapy as planned, and you are followed till approximately day 35, which is approximately the end of induction. There is this arm C, the rescue arm, so that would be for patients assigned to no prophylaxis who develop hepatotoxicity, who are then able to receive levocarnitine as a rescue agent. Of note, practically, once a site opens the study, they will be supplied with a set of starter tablets. It is expected that the majority of patients on this study will take levocarnitine orally. There is a tablet, there's a solution, and there's also an IV supply. The sites will only have tablets as a starter, and there's on-demand shipping for subsequent supplies based on need. I mentioned there's a patient-reported outcome quality of life aim that is really focused on peripheral neuropathy. This is an optional part of the study. Patients can choose to opt in or opt out, and it's very limited. There's 2 time points, baseline and end of induction. There are multiple integrated biology tests, and really these are will be based on serum at multiple time points, and also a single germline DNA gathered at the end of induction. The planned study accrual is to obtain 420 evaluable patients. with the design being based on a impact of levocarnitine in decreasing the incidence of conjugated bilirubinemia by 50%. The randomization stratified by obesity and also randomized by pediatric versus adult groups. There is planned futility and efficacy assessments, given that the estimate of 50% reduction is based on real world data and some data in other settings. There is a planned reassessment to ensure that that is neither way too high or way too low along the way. And lastly, the study is open. This study is out of date. This is a study from when the celebration, when it actually went live, when the first patient was enrolled. It is still in early days. Their enrollment is up to double digits, both at adult and pediatric sites. But it is open and ready to enroll. Last few things. So it lives both on the COG, but the NCTN site. Again, the study chair wanted me to remind you about the starter set of tablets. There are kits for biology specimens, and the study is open. And with that, I'll just acknowledge the large group of people, and really Itan Orgel, who has been the person who has led this. And with that, I'm happy to take any questions.
Thank you for the wonderful talk, Dr. Alexander. I'd like to ask the audience to please input their questions into Slido or the Zoom chat. So it looks like we have a couple of questions. So our first question being, what are some current standard interventions to prevent liver damage for the AYA population?
So I would argue that most people would say there aren't any. I think there are some strategies used, I think, again, more in adult care than in pediatric, actually not used in pediatric care, maybe used sometimes in adult care around dose capping of asparaginase, but it's not clear that dose capping or the dose of asparaginase is actually related to the chance of having this sort of liver toxicity. I think there are some places that are potentially using levocarnitine sometimes. I think it's the vast minority, and again, without clarity of the sort of benefits or risks.
Thank you. And moving on to our next question. Why are AYA patients at higher risk for hepatotoxicity during ALL induction?
Yes, that's a great question. I think there's very consistent data that AYA patients compared to 2-year-olds or 5-year-olds or 10-year-olds are at risk for essentially every toxicity at higher rates and probably at higher grades of severity than younger kids. So, and whether the threshold should be 15 or 12 or 18 for this toxicity specifically, I think was hotly debated, but it clearly goes up with age. Why that happens is an excellent question that I think for this toxicity and others, I think that is largely unknown.
Thank you. And moving on to the last question, would you say that this trial contained unique elements compared to other trials that are also focused on providing supportive care?
I mean, I think this trial is very focused on its specific aspect of supportive care that it's trying to do. It's trying to, prevent conjugated bilirubinemia in the first 35 days of ALL therapy. So it is very focused. It is clearly not a broad scope of supportive care in all its aspects. The maybe not a unique element, but a unique feature of this trial. So this is I think the first, standalone supportive care trial being done in a cooperative manner between the pediatric and adult groups. So I think there's, in addition to the interest in learning about levocarnitine, I think there's interest in learning about the feasibility and the barriers and the things we'll need to learn about trying to carry off a supportive care trial in a specific patient group across both adult and pediatric centers.
Thank you for your answer. And if there aren't any remaining questions, I think we're going to end this Q&A segment. So we would like to thank Dr. Alexander again for her very insightful talk and ask the audience to please email us any remaining questions you may have about this trial so we can direct them to Dr. Alexander and then share the answers with you at a later date. Now moving on, it is my honor to introduce our last distinguished speaker, Dr. Michael Crump. Dr. Crump is a professor in the Department of Medicine at the University of Toronto and clinical investigator in the Cancer Clinical Research Unit at Princess Margaret Cancer Centre. Dr. Crump's research interests include applied molecular oncology and clinical and translational lymphoma research, with focus in stem cell transplantation, developing novel therapies, and exploring the late effects of treatment. Today, he will be presenting on a randomized phase 3 trial studying brentuximab vedotin in early-stage Hodgkin lymphoma. Please join me in welcoming him to present on this innovative clinical trial. Dr. Crump, would you be able to share your screen? And if there are any technical difficulties, please let us know and we can share your slides instead.
Good afternoon, everyone. Can you see my slides?
Yes.
So on behalf of the network of investigators in Canada that belong to the Canadian Cancer Trials Group, thanks for the opportunity to present this, we hope, innovative study. So I'm presenting this on behalf of many people in our group. So the general goals in the management of early-stage Hodgkin lymphoma are fairly straightforward. We're trying to maintain a very high cure rate in a population of patients that on average is quite a bit younger than the average person with cancer in our country. So the median age of a diagnosis of Hodgkin lymphoma is about 35 years. So people who've gone through therapy have a lot of life years ahead of them where late toxicities might arise. So we have the joint goal of trying to improve the effectiveness of chemotherapy by adding new agents. And this would hopefully reduce the need to include involved field radiation, which has been a standard treatment for in limited stage Hodgkin lymphoma for many years. It's worth bearing in mind that both chemotherapy and radiation do contribute to the long-term morbidity of or burden of late effects in Hodgkin lymphoma survivors, but most of the evidence points towards extended field or involved field radiation as being responsible for this. So how would we go about doing this? This study will test whether incorporation of novel agents that are not, strictly speaking, chemotherapy might improve the outcomes of individuals with Hodgkin lymphoma. So a little bit of background. It's already been demonstrated that the chemoimmunoconjugates or antibody drug conjugate brentuximab vedotin has already achieved the goal of better disease control in advanced stage Hodgkin lymphoma in adults. So these are the data from a study called Echelon-1, where standard ABVD chemotherapy, we'll show you what that acronym means shortly, was compared to a novel regimen where bleomycin was removed and brentuximab vedotin, this CD30, the chemoimmunoconjugate, was added. Initial publication showed that progression-free survival was improved with the addition of brentuximab vedotin replacing bleomycin. And subsequent studies have actually shown that this progression-free survival was maintained, and overall survival improvement was also recently reported last year. So the study that in Canada is going to be called HD12 is actually has its origins in the UK with the UK Lymphoma Group. They call the study RADAR. And this is really a follow-on of a Cancer Research UK study called RAPID, which was one of the first PET-guided treatment studies to look at the role of FDG PET imaging in guiding further therapy in patients with limited stage Hodgkin lymphoma. So this study, the RAPID study, published a number of years ago, was a randomized trial of omission of radiation for patients with limited stage Hodgkin lymphoma, stage 1 and stage 2, non-bulky, who had a negative PET scan after 3 cycles of chemotherapy. The UK standard at that time was to give 3 cycles of chemotherapy and give everybody involved field radiation. And the study tested whether or not those with a negative PET scan after 3 cycles really needed to have such treatment. So it's a pretty large trial, coordinated by the University College London Clinical Trial Centre. And the study showed that overall survival was actually the same in patients who had radiotherapy omitted based on their post-cycle 3 PET scan. But in terms of progression-free survival, in terms of disease control, it was a little bit inferior. So leaving out radiation does decrease the benefit somewhat of the overall treatment package in terms of progression-free survival, but fortunately, to this point in time, has not affected overall survival. So PET-guided treatment really is the standard of care for individuals with limited stage Hodgkin lymphoma. This rather busy slide just shows you that a number of other studies have been subsequently published that have used a PET-adapted approach after 2 cycles of chemotherapy to guide further treatment decisions in this patient population who have a good outcome but face late effects. So studies by the EORTC at the top, and then 2 German Hodgkin study group trials at the bottom have used a PET-adapted approach to maintain high rates of complete remission, good progression-free survival without necessarily having to escalate therapy or even include involved field radiation. So HD12, which is the what this study goes by through the CCTG, is a PET-guided trial. This is the study schema. So all patients will be randomized stratified based on an EORTC risk score, which categorizes patients as early favorable or unfavorable based on some disease attributes, as well as whether or not it's actually intended that the patient would receive radiation at the end of treatment, regardless of their PET outcome. That's a decision that's made by the investigator. We'll comment on that later. So everybody will receive will be randomized to either a standard ABVD induction treatment or the experimental arm, which includes brentuximab vedotin and AVD, just like in the Echelon 1 study that I just showed you. And then depending on what the response is as adjudicated by a PET scan after 2 cycles of chemotherapy, patients with a complete response will receive 1 further cycle of chemotherapy and nothing more. Patients who have a less than a complete response will receive 2 additional cycles of chemotherapy. And then in the majority of cases, if the PET scan is negative, they'll stop therapy or they can continue on to radiation. Patients who have evidence of disease progression, which is shown here at the bottom, will come off study and receive alternative therapy. So the main study aims of this trial are to improve progression-free survival. That's kind of the currency of treatment effectiveness in the lymphoma world, a measure of disease control over time. It's to improve the complete metabolic response rate, thereby providing a larger number of patients who perhaps don't require involved field radiation at the end. Ultimately to improve overall survival, but additionally reducing late toxicity by reducing the number of patients who require additional treatment, including involved field radiation. And the 5th aim is to look at pulmonary toxicity. The primary study endpoint is progression-free survival. There are 2 main secondary endpoints, the PET complete metabolic response rate after 2 cycles of treatment, comparison between the 2 arms for that, and then event-free survival. Events in this study really are essentially the addition of non-protocol therapy in response to an abnormal PET finding along the way. Overall survival is an important secondary endpoint. Secondary cancers and cardiovascular disease, toxicity differences between the 2 arms, as well as CCTG-led assessment of quality of life and economic analysis, both of which are being led by our economics group, particularly by Dr. Anka Prika. So inclusion criteria, adults between the ages of 16 and 69. Patients have to have a histologically confirmed classical Hodgkin lymphoma based on a core biopsy or an excisional lymph node biopsy. Because this is a study that's built on prior work done in the UK, there were some particular patients that were excluded. So patients without in this trial will not be allowed in if they have bulky mediastinal lymphadenopathy or if they have B symptoms, fever and night sweats and weight loss at the time of presentation. Bulky disease at other sites is allowed. Extranodal extension from a non-bulky mass into the lung or to the chest wall, which would be a common presentation, are allowed in this trial and still considered to be limited stage. But patients have to have a good performance status, no prior therapy for Hodgkin lymphoma. It's not unusual for patients to have a lot of symptoms at the time of presentation. They often benefit from a short course of prednisone while we're preparing their staging and their treatment, and that is allowed in the context of this trial. And patients have to be fit enough to receive doxorubicin-based chemotherapy. So patients with a history of cardiovascular disease or hypertension will be required to demonstrate a normal left ventricular ejection fraction. We suspect this will be the minority of patients in the trial. There's many exclusion criteria in randomized trials. These are the sort of the key ones. This is a study that's only intended for patients with disease above the diaphragm. So those with infradiaphragmatic Hodgkin lymphoma, limited stage will be excluded. Nodular lymphocyte predominant Hodgkin lymphoma, at least in the adult world, is no longer considered to be Hodgkin lymphoma at all, but probably a low-grade lymphoma. So while our other studies would have included this histological subtype, they're excluded from the current trial. Everybody has to have a FDG avid or a measurable, accessible lesion on a PET scan. So if somebody has a excisional lymph node biopsy, say of a neck node, and there's no more lymphoma, they're not eligible. Typically in an adult population, second cancers are an exclusion. In situ carcinomas of any site are still allowed, and patients with non-melanoma skin cancers are eligible, but anything beyond that is an exclusion. Because neuropathy is one of the limiting toxicities of brentuximab vedotin, other patients with a pre-existing sensory or motor neuropathy are excluded. This is a study that's not intended for patients with HIV-related Hodgkin lymphoma or patients with active, uncontrolled hepatitis B or C and pregnancy and breastfeeding, of course. So just in terms of the practical delivery of this trial, this is a cooperative group funded study. And it's meant to largely reflect clinical practice in countries like the UK or in Canada, where we try to be practical about imaging tests and things like that. So baseline assessments include, we're trying to collect data about smoking history, something that's unfortunately often omitted. So that's pleased to include that. Pulmonary function tests are required for this study, even though in clinical practice they may not be something that is commonly obtained, because one of the secondary endpoints is to look at lung toxicity. Echocardiograms are required based on what I described earlier in terms of cardiovascular risk factors. Everybody has to have a baseline PET scan and some biochemistry. There's a much longer list of required elements, but they're fairly standard for a randomized trial in adults. So for those, just to remind everybody what ABVD and what brentuximab AVD is, or A squared AVD, the dose and schedule of the drugs is listed on this slide. It's very, very standard regimen with bleomycin in it. The dose of brentuximab vedotin is 1.2 milligrams per kilogram. This is the dose that's been successfully added to Q2 weekly regimens like ABVD. But otherwise, the dosing is identical. It's required that patients receive growth factor support with GCSF in the in the brentuximab AVD arm because of a higher rate of febrile neutropenia without it. But and whatever GCSF product is standard of care can be administered. So during treatment, patients have to have blood tests before before dosing at any chemotherapy scheduled. There is an optional post-cycle 1 PET scan. There's a lot of interest in the nuclear medicine group from the UK in looking at the prognostic value of a post-cycle 1 treatment. So this PET scan, so this is actually just after 2 doses of ABVD or AAVD. There's central review of this. The results of this study do not affect the patient's treatment. The results will not be provided to this of the central review will not be provided to the investigator, but of course, all of this imaging will be locally reviewed. But the key investigation along the way during treatment is post-cycle 2. So as I showed you on the earlier slide, patients with a complete metabolic response in either arm will have 1 additional cycle of therapy and then stop. Patients with a partial metabolic response will have 2 further cycles of treatment that involve nodal radiotherapy, and then treatment failure. These results or the clinical action are going to be based on the central review, not the local review for this particular study. So this is really sort of where the action is after 2 cycles of treatment. The scans have to be done between days 26 and 29. 26 and 27, so that the results are available. The turnaround time for this is actually, at least in the UK and Europe, is actually quite brisk. It's within 48 hours. I'll mention the pathway to central radiology review shortly. So busy slide of the follow-up assessments. The top part of this is really kind of standard things you would do with anybody in a clinical trial, the clinical assessments and performance status and some blood tests. I think what's important in a pragmatic cooperative group trial like this with modest clinical trial funding, the imaging actually reflects what the standard of care is. So at least in the UK and in Canada, once it's been established that patients have had a complete response, or once their post-treatment imaging is completed, then there's no obligatory further imaging. So progression-free survival is really going to be captured in the way it would be in the clinic, which is based on patients' clinical signs and symptoms that when they present to you, there's no.
I feel like the speaker dropped out. So it seems the speaker dropped out. Let me.
It's a sec. I think I was telling you that additional imaging along the way. Can you hear me?
Yep, we can hear you.
Okay, is not required, which makes it easier, a little bit easier on centers. So this is a very large trial, over 1,000 patients planned. It's intended to, or was estimated on the basis of the the RAPID trial that progression-free survival at 3 years would be about 90% with an ABVD-based approach. And this trial is looking for a 5% improvement and 95% with the addition of brentuximab vedotin, with a fairly generous hazard ratio. So in order to detect this improvement in progression-free survival, we require 69 events, and with 5 years of recruitment and 3 years of follow-up for the whole group, is going to require this 1,000 patients. So the Canadian commitment to this study through the CCTG is 200. We are partnered with a number of high-volume centers in the United States, University of Miami, Dana-Farber, Stanford, and others. So it's expected that the North American contribution to this trial will be about 400 patients, with Europe through the ERTC, Australia, New Zealand, and the UK contributing the rest of the patients. The sponsor in North America is the Canadian Cancer Trials Group, Kingston. And just a couple of last points involved. Nodal radiation is allowed in this trial. This must be declared prior to the start of therapy. So if the investigator feels that the patient would benefit from radiation, even if they have a complete response, and the available data would say that's a reasonable choice, then that's allowed, but it has to be that declaration has to be made before the patient is randomized, so the application of radiation is balanced into two arms. There's two areas where radiation is recommended. Patients over the age of 60 who may not be candidates for some second-line therapies, such as autologous stem cell transplant, and patients with maximum tumor diameters, over 5 centimeters at the time of presentation. There's a lot to do within this trial in terms of the central radiology review. So this is just a couple of screenshots from the CCTG website. This is, if you go to HD12, you'll land on this place that has a whole bunch of tabs you can open. And in particular, there is a manual, a laboratory manual for the correlatives. Our group, through Christian Steidl's lab in Vancouver, is leading the correlative biology evaluation for the North American patients. So we're collecting, in particular, blood, but also biopsy specimens. So that's all outlined in the lab manual up at the top, and then the manuals for central, how to do central imaging review, which will also be happening in Canada through British Columbia and through the Princess Margaret Hospital. There are manuals for those aspects of this trial as well. In issues of time and space, I didn't cut and paste any of how that works, but there's rich resources in terms of supporting sites in their participation in this trial and these really important correlative studies. So with that, I'll conclude my presentation, and I'm really, really sorry that my battery died in the middle of it.
No worries, Dr. Crump. Thank you for your presentation. I would like to ask the audience now to please input their questions into Slido and Zoom. So I can see that we have our first question. As this is an AYA trial, will it be planned to open in ped sites? We see only 2 adult sites are open.
So the study was just centrally activated on the last part. The study has only recently been Health Canada approved and centrally activated. And in fact, we're actually having the sort of national investigators meeting shortly, probably in the next couple of weeks. It's been discussed as to whether or not a pediatric site could join, and more to follow on that. It wasn't specifically aimed at pediatric centers, at least in North America. The reason for the difference for the 16 to 17-year-old age group is that in many centers, those patients are automatically treated in adult centers. But I don't know if Dr. Alexander's still on the line, but further discussions about whether or not the C17 sites could join, I guess, would follow, but it would be within a relatively narrow group of patients.
Thank you. And moving on to the next question. What do you predict the quality of life impact will be on patients who are involved in this trial?
So it's known that, at least in the short term, that some of the toxicities of brentuximab vedotin could significantly have that impact, particularly because of peripheral neuropathy. So that was kind of the most notable difference in the adult study, that in advanced stage disease. So that may be one area where quality of life differences arise. The second might be just due to differences in toxicity, such as myelosuppression, which is actually greater in patients receiving brentuximab AVD than with ABVD. So slightly higher risk of febrile neutropenia and having to be in the hospital. But the duration of therapies here is actually quite short. So it's quite possible that there won't be really appreciable differences between the two groups, but we don't actually know.
Thank you. And moving on to the next question. As there are two trials running in parallel, why is it necessary to do two trials rather than the traditional way?
Are you referring to the fact that Canada, it's being run in Canada and in North America separately versus the rest of the world? Which I think is what's behind this question. That's 100% administrative. It has to do with who provides the drug with the brentuximab vedotin around the world. So outside of North America, it's Takeda. But in North America, it's Seattle Genetics. And they operate somewhat separately. So it's a really long story, but the structure of this, the protocol is exactly the same. But because of regulatory and administrative things that have to do with the pharma industry, largely, they're kind of like two parallel trials where the data are going to be constantly combined along the way. So it was a reality of the pharma world.
Thank you. And for the last question that's stated, you indicated this is an innovative trial. What element makes it novel or innovative than other trials of this kind?
I think it's the inclusion of, I guess, the first in line of newer generation of agents that we know to be active in Hodgkin lymphoma. So it's trying to depart with the chemotherapy components that we've relied on for the treatment of Hodgkin lymphoma for the last 50 years, and insert a drug, an antibody. This would be the first antibody, I guess, derived therapeutic that's been tested in early stage Hodgkin lymphoma. There's others that are likely on the way. You may be aware that there's a North American trial that's going to include a PD-1 antibody plus brentuximab vedotin in the early stage Hodgkin lymphoma as well. So I think one of the things that we're trying to do is remove chemotherapy when possible from early stage Hodgkin lymphoma and replace it with these other agents that are not strictly speaking chemotherapy, and we hope will have at least as good efficacy and better tolerability. Hodgkin lymphoma, I'll just add my final editorial, is even though it's not a very common cancer, it's extremely well studied disease. There are more than 50 randomized trials of what to do. And I think it's because of the caution around the high cure rates and then the sensitivity. We want to maintain that, and the sensitivity to the fact that these are individuals that are going to live for quite a long time if they're cured, and then have secondary cancers and other cardiovascular conditions. So we're trying to minimize those things, and we've exhausted what chemotherapy can do, I believe, and we're now looking to novel agents.
Now, as a personal question that I have as a research student at 3CTN, I'm interested in oncology, and I was just curious as to what has inspired your interest in treatment-related toxicities within your research.
I think it's probably what I just mentioned, the latter. These are I see a lot of young people. I think all hematologists and oncologists who treat lymphoma do, and having a cancer at a young age as a young adult has a big impact, for sure psychologically, but also in terms of morbidity. So the lymphoma survivor population, at least in North America, is the largest population besides women with breast cancer. So there's a lot of people out there that have lived many years and had to endure, at least from treatments that were given in the past, have had to endure a fair bit of side effects. So we've seen what extended field radiation can do in terms of causing heart disease, and all kinds of heart disease and stroke later on in life at a higher rate than you'd expect in the general population. And the big ticket item has always been second cancers. So we know that the exposure to chemotherapy and radiation, or just even chemotherapy alone, does increase the risk of a second cancer in the Hodgkin lymphoma survivor population. So these are patients that are around in our clinics for many, many years, and sometimes they come back with something, that they have some sort of cancer or some other medical condition they otherwise wouldn't have had they not received chemotherapy and radiation in a curative fashion for Hodgkin lymphoma.
Thank you for sharing your answer. And in the interest of time, we're just going to end this Q&A session. We would like to thank Dr. Crump again for his insightful talk, and please ask the audience to email us any remaining questions so we can direct them to Dr. Crump and share the answers with you at a later date.